disability, and so it is a loading problem, not only for the patient, but also for the family and for the society, and causing too much cost. When we speak about sepsis, really we have to ask many questions, and I think it's nice. All our questions and all our queries will be answered by our famous guest speakers. We have to ask about what is the meaning by early goal therapy. What is the difference between early goal therapy and late? And what is the optimum time? 2 hours, 1 hour, 6 hours. And as we know, every year or every 2 years or every there is a new definition for sepsis to try to avoid missing acute stage or missing diagnosis of septic patients. Also, we have to ask about many problems in sepsis. About antibiotics, for example, we have to start empirical antibiotic without culture or directed therapy, better and waiting the culture results. This is very important. And if we start empirical, what is the rule of steward regulation of this antibiotic after that? There are many points also which will be answered by our guest speakers, inshallah, about the role of steroids and at what time we have to use, the role of statins, the role of nutritional support and immune modulation. What is the role of vitamin C, vitamin D, and. And what is the meaning of dysregulation of immune response? This meaning hyperimmunity or low immunity or hyperinflammation and the cytokine storm, and how to avoid the role of anticoagulant and even thrombolytics in such situations. At what time we have to use it? Many questions really also. What is the role of CRT and the hemofiltration especially, and if it decreases the cytokine storm and improves the patient result? All these are questions, and we have to share our guest speakers and their experience, which is, I think, professional experience. And really, I am lucky today, and I'm lucky this night to introduce my dear colleague, Dr. Hisham Ataya from the Gazig University. He's working now as an intensive care consultant in King Abdullah Medical City in Mecca, Saudi Arabia. And I hope to sharing him and try to help me for welcoming him. Welcome, Dr. Hisham, and the mic for you.
Welcome, Dr. Ansari. Thanks for this intro. Inshallah, it is my pleasure to join this great team and great webinar regarding sepsis, and to be a presenter also in this webinar. It is an honor to me, inshallah. Today, inshallah, I will go directly to my topic, which is a 1 hour approach to a septic patient. Let me adjust something first. Okay. Our objective today, inshallah, to understand sepsis as a life-threatening disorder, sepsis pathophysiology, and the importance of early intervention if we discover the patient in sepsis, and our one bundle priorities and targets. Despite the best efforts and protocol-based management, sepsis is continued to be a significant healthcare issue. It carries high mortality. Up to 25% of sepsis may die, 50% if patient went in septic shock. The Global Burden of Disease study in 2017 reported that sepsis occurred in up to 50 million people worldwide, ending to a death of 11 million, which represent up to 20% of the global deaths. NHIS reported 2019 that sepsis is the leading cause of death in non-cardiac ICU. So sepsis, another issue of sepsis is regarding increasing mortality. It also increasing morbidity. 40% of sepsis survivors after a prolonged ICU stay were found to have a range of physical, psychological, and cognitive complications. Up to 43% of sepsis survivors is found in one study did not return back to work for 1 year. Sepsis is also considered as a burden on resources. It costs 17 billion per year. This is a very important slide. This is important diagram and the flow chart, which we can start with a patient, healthy patient, when he develop infection. Either he will go to appropriate host response or inappropriate host response or exacerbated host response, which will end by, if appropriate response, he will end by recovery. If inappropriate response, by organ failure, sepsis, and it may go secondary infection, ICU stay, prolonged ICU stay, and chronic illness, which was persistent inflammatory immune suppression and catabolism syndrome, may later on end by recovery or long-term complication of sepsis and morbidity, or may end by this, as we discussed before, it is up to 50% may die from sepsis. So what is infection? Infection occurs when a germ enters body inducing tissue damage. If we have appropriate host response, balanced response of pro-inflammatory and anti-inflammatory mediators, infection will be controlled, tissue healing will occur, and the recovery is the final destination. Some people did not go with appropriate or balanced response of pro-inflammatory and anti-inflammatory, so going into exacerbated and unbalanced or dysregulated host response to infection, and end by associated with organ failure. This is what's called, we have a sepsis. So sepsis by definition is related from infection, dysregulated response, organ dysfunction, and life-threatening, as discussed, affecting morbidity, mortality, and cost issue. So as per sepsis campaign definition, sepsis is a life-threatening organ dysfunction due to dysregulated host response to infection. So why dysregulation happen? Actually, it's of unknown cause. We don't know why patients develop dysregulated response. Imbalance between the pro-inflammatory and anti-inflammatory. So, but we have high-risk patients. We have to keep on our eyes on this high-risk patient. High-risk patient, elderly people, more than 65 years. They found the age by itself. It's an independent predictor of mortality. Immune suppression, our immune-compromised patient or cancer patient have tenfold increase in risk of developing sepsis. Community-acquired pneumonia causing sepsis, around 50% of community-acquired pneumonia develop sepsis and 5% develop septic shock. Previous hospitalization, it carry up to threefold increase the risk of developing sepsis for subsequent 90 days for patients, especially who are receiving antibiotic. Intensive care unit admission, also it carry risk of nosocomial infection up to 50%. Positive blood culture, bacteremia, 95% of patients develop bacteremia, develop sepsis and septic shock. And some genetic predisposition, we may found some people with genetic predisposition to develop sepsis. So second point we have to know about it, organ dysfunction. What is the definition of organ dysfunction? Organ dysfunction is defined in sepsis campaign as an increase in SOFA score by at least 2 points from the baseline. So what is SOFA score? SOFA score is a sequential organ failure assessment score. It's used only and mainly in ICU, and it used to predict mortality. It assesses the severity of dysfunction for 6 organs: CNS, cardiovascular, respiratory, GI, renal, and hematological disorder. It should be calculated on admission to ICU, then every 48 hours. SOFA score now is available in Medicalc. You can go to Medicalc and put the parameter of your patient and the vital signs and the lab finding, and then you will find the SOFA score. So if we reach 2 SOFA score or more, so we have per definition organ dysfunction. And if we reach 2 or more, 2, it equals 20% mortality. If we see here, if we have a patient with a BF ratio less than 300, with creatinine raised from baseline to more than 2, liver dysfunction, and cardiovascular is hypotensive, and with thrombocytopenia, with GCS is low, it may reach mortality up to 95%. SOFA score, it is not applicable for screening, especially outside ICU. Outside ICU screening, it needs something simple, fast way to screen patient outside ICU. because most of the required data for SOFA score are not usually available at the bedside. And also SOFA score is not applicable with pregnancy. We have some physiological changes which occur with pregnancy overlap with the criteria for sepsis. So for this two difficulties, they made for screening a very simple, very fast, what is called quick SOFA. It is the three simple parameter: altered conscious level, blood pressure, and respiratory rate. And if quick SOFA score two or more, it is by definition possibility or susceptibility of the development, the presence of sepsis. And it is used mainly outside ICU, cannot be used in ICU. But quick SOFA score have some limitation. It is low sensitivity, up to 50%. It identified patient late in the course of sepsis and needs a careful interpretation for defining sepsis. The physician should know if this patient already has changes in the baseline status related to infection, and he should know also the pre-existing chronic disease. If patient already has a stroke, the disturbed conscious level from the start, his basal blood pressure around 90, so he should decide this patient already in sepsis or not in sepsis. For pregnancy, due to the overlap of the physiological parameters, there is a sepsis in obstetric score, SOS score, which makes some modification of the vital signs and the parameters related to the physiological changes. But actually, this score is still under validation, is not approved till now. Why organ dysfunction happen? If we have a patient that we know the definition of organ dysfunction, what is the mechanism of organ dysfunction for in sepsis patient? If we say the high-risk patient exposed to pathogen, it will go in cytokine storm, imbalance, increase pro-inflammatory more than the anti-inflammatory, activation of different systems. This different system complement coagulation cascade, platelet, endothelium, polymorph. I will go to the next flow chart. It will explain it more easily and more clear explanations. So if you have this regulated response, more pro-inflammatory mediators, with this activation of coagulation cascade, which make more than the fibrinolytic system, make microthrombi, affecting the capillary perfusion itself. Activation of polymorphonucleosides, it will stimulate endothelial injury and increase permeability and the tissue, then tissue edema. Again, tissue edema, it will make more pressure and encouragement on the microcapillaries. Endothelial injury also and stimulation increase prostacyclin and nitric oxide, which is causes vasodilatation, then hypotension. Loss of the autoregulation, and autoregulation is the main concern if a patient is in shock. Autoregulation is the mechanism by which the body can divert or shift blood from non-vital organs to vital organs, brain and the heart. In sepsis, due to nitric oxide and the prostacyclin, patient and the body failed to control or to loss of its autoregulation mechanism. This myocardial depression occurs due to mediators and decreased cardiac output. Erythrocytes also, it lost its normal ability to deform, so failed to go through the microcirculation. So from this, all initial four parameters we found, we have decreased oxygen delivery, hypotension and hyperfusion, and oxygen and the RBCs itself, we cannot go through the microcirculation. So we have a point here, decreased oxygen delivery to the cells. Even the cells, it may be affected with mitochondrial dysfunction. Even if the blood, if the oxygen reaches the cell, it cannot utilize it. Failure to utilize oxygen due to mitochondrial dysfunction, which happens with this dysregulated host response. Activation of different cell pathways and causing more injury. So by this, we have widespread cellular injury and organ dysfunction, which may end by septic shock, and which is by definition sepsis campaign, fluid refractory hypotension requiring vasopressors, with tissue hyperfusion documented by rising lactate more than 2. So we have no organ system immune against the complication of sepsis. No organ is protected from consequences of sepsis. Say in nurse cardiovascular respiratory, we have up to 50% may develop acute encephalopathy related to sepsis, 60% cardiomyopathy, and 7% of septic patients may develop ARDS. Again, we go again to our important slide, which through it we have to know, we have to block or to break this cycle. We have to early recognize patients' infection and sepsis, and we have to go for early intervention to prevent this great complications or major complications of morbidity, mortality, and the cost. Early recognition, it should be through awareness, community awareness of medical staff, and by screening. We have to put a system of screening to early recognition of patient and sepsis. In KMC, alhamdulillah, initiated by the help of Dr. Adel Hussein to reach a plan for sepsis alert team and screening, still under processing and hold for a while because of the corona status, and inshallah we can resume after within the coming months, inshallah. Early intervention, as per SIPS campaign, we need a team to follow and to manage. We have to go through the evidence-based guideline or evidence-based recommendation, which is our one bundle. Our one bundle, actually, it is 5 points mainly. Measuring lactate, blood culture before antibiotic, broad-spectrum antibiotic, begin IV fluid, and apply vasopressors if indicated. We'll start by the first one, which is lactate. Lactate, measure lactate and remeasure if initial lactate more than 2 millimole per liter. This is the pathway which we end by production of lactate. If we have glucose metabolism, it may go to anaerobic pathway and end by energy production, or end by anaerobic pathway and giving us lactate. So in general, if patients will have hyperlactatemia, we have many causes of hyperlactatemia. It may be exogenous if we are using lactate as a buffer during CRRT machine, or endogenous. The endogenous come from overproductions of pyruvate, glucose, increased glycolysis, and overproduction of pyruvate. So glycolysis may be due to basal metabolic rate issue, beta-2 agonist stimulant, we are seeing epinephrine use, it's a beta-1 medication, or it may be another, we have another substrate for this increased pyruvate production. We have hematological malignancy, which is the commonest finding in ICU to find patients with hyperlactatemia due to underlying hematological malignancy due to overproduction of pyruvate substrate. Second, if we have a problem in pyruvate clearance, like pyruvate dehydrogenase problem, which you are seeing due to thiamine deficiency, metformin toxicity, and in some people with congenital disorders. We may have another point regarding pyruvate clearance, which is due to mitochondrial dysfunction, due to decreased oxygen delivery, cyanide toxicity, or drugs. Commonly, we're using antibiotic, which is one of the medications which may increase lactate due to its effect on mitochondrial dysfunction, oxidative phosphorylation process. And we have if we have anaerobic production of lactate, if we have liver impairment, renal impairment is a matter of clearance. So in sepsis, we see patient in sepsis, we may use epinephrine, we may use, sepsis also documented to have a thiamine deficiency, we may have a sepsis in hematological malignancy, we may have oxygen delivery decreased as discussed in pathophysiology, antibiotic use of linezolid, organ dysfunction, liver and the kidney. So this is the main causes of increased lactate during sepsis or septic shock. Lactate is a marker of tissue hypoxemia and ischemia. It does not diagnose sepsis. As I said, we have many other causes rising lactate, not related to the sepsis, but it can tell us how bad the circulation and the tissue oxygenation is there. We can make use of or get benefit from monitoring lactate in sepsis. It may identify for us early detection of what's called cryptic shock. Cryptic shock is the patient in shock while preserved blood pressure. So blood pressure is not a marker of shock. Tissue hyperfusion and hyperlactatemia or tissue hyperfusion is the marker of septic shock, what's called cryptic shock. Preserved blood pressure with tissue hyperfusion. It predicts outcome. If we have still rising lactate despite our management or rising lactate outside in the floor, it may be an indication for poor outcome and they may need ICU admission to ICU. It helps to guide therapy. If we can lactate to decrease with fluid challenges as a monitor, this one of the indication, it may help us to decide we may go for fluid challenge more and more. Second point is a straightforward point. We need blood culture before giving antibiotic. It's not a matter, get blood culture before giving antibiotic. But I will give them some practical points, it's very important. So don't delay antibiotic to get the culture. If you have a problem in the resources, problem in the bottles availability, problem in the availability of the staff getting the culture, give the antibiotic, don't delay. Don't send blood culture from any vascular devices inserted less than 48 hours. It is unlikely to be a source of infection. Fill aerobic bottle first if you don't have enough sample, as most organisms grow mainly aerobically. In 50% of patients, the source will not be determined, which is culture negative sepsis, which can be seen in respiratory tract infection, are the commonest site to be culture negative. But urinary tract infection are the likely to be a culture positive. Other causes of culture negative: receiving antibiotic prior to admission, insufficient or incomplete diagnostic workup, unusual organism, or this situation is not related to non-infectious cause. Let me go with culture negative. Give broad spectrum antibiotic. And in delay of antibiotic more than 1 hour, it will increase mortality. Appropriate empiric antibiotic should be based on or guided by the possible source, their immune compromised patient, local antibiogram, risk factor for resistant organism. For the possible sources, they found pneumonia represent 50% of the cases went on sepsis and septic shock. Urinary tract 20%. The least causes of sepsis or septic shock: endocarditis, device-related meningitis, and others, which represent totally 5%. We have to know also, inappropriate antibiotic use or improper selection, it will increase mortality by 34%. The best way, of course, to know the antibiotic is to know the organism by the culture and sensitivity and to know the MIC, but it needs time. De-escalation and the early cessation of antibiotic should be discussed daily. Antibiotic 7 to 10 days course of antibiotic is appropriate for most infection, but we may need longer course of treatment if we cannot control source in immune compromised patient in a special situation like Staph aureus bacteremia, endocarditis, and fungal infection. The fourth point is to start to give fluid. As per sepsis guideline, they recommend to infusion of intravenous fluid, 30 ml per kg, starting within the first 1 hour and completed within the first 3 hours of presentation. But does it applicable for all patients? For all patients, we have to give the 30 ml per kg. What about renal failure patient? What about heart failure patient? What about ARDS patient on mechanical ventilation and conservative management? So to know we have to go for all patients or not, we have to know some facts there. The only reason to give IV fluid is to improve our cardiac output. If we have patient, if I give fluid to a patient, what I waiting for the result? To increase cardiac output. If cardiac output not increasing, so the patient will not get benefit. Not all shock patients will get benefit from giving fluids. Approximately 50% of fluid bursts fail to improve cardiac output. Giving unnecessary fluid exposes the patient to a volume overload, which worsens patient outcome. A lot of studies supporting the concept of conservative fluid resuscitation and document the worsening in the outcome and volume overload, like FACT trial, FAST trial, FEAST trial, many trials going with conservative, which is improving the outcome and tissue edema and renal replacement therapy, positive balance and giving more fluid and volume overload, it will end by increased mortality. So why not all patients will get benefit from giving fluids? So according to Frank Starling principle, the preload increase, the stroke volume increase up to limit. This is the curve. In preload increase, stroke volume increase. Straight part. In normal physiological condition, both ventricles operate in the ascending portion of the Frank Starling curve. Once the left ventricle is functioning near the flat part of the Frank Starling curve, the fluid loading has little effect on the stroke volume. So here, so we need our patient to be in this flat part. So we have to find the fluid responder, which benefit from fluid resuscitation. By giving, when I give a fluid, he should have increase in the cardiac, in the stroke volume and the cardiac output, and with reasonable rise in the preload. If we reach here, you will see here we have large increase in cardiac output in this area, but here we have a small increase in cardiac output, but large increase in the extravascular lung water, which carry risk of volume overload, more worsening of the hemodynamics, more volume overload, and worsening outcome. So ascending portion of the Starling curve is our target to find our patient here. How to determine fluid tolerance and the fluid responders? We need two things. We need 2 points to reach, must be met. We have to create a change in preload, and we have to assess this change in the preload and the effect on the cardiac output and stroke volume. The change in the preload is divided mainly in 3 points. A change in preload with heart-lung interaction, change in preload with fluid challenge, change in preload by fluid redistribution. So a change in preload, heart-lung interaction, as we know, they are make use of the change in the interstitial pressure during inspiration and expiration. During that time, during inspiration, finally we have decreased right ventricular stroke volume, but we have increased left ventricular stroke volume and increased blood pressure. During expiration, the reverse is here. We have decreased the left ventricular stroke volume. So blood pressure increased during inspiration, and the pulse pressure increased during inspiration, and decreased during expiration. Through non-invasive cardiac output monitoring, we can check these variations: pulse pressure variation, stroke volume variation, systolic pressure variation, or VTI by echo, or vena cava indices. I will not go in details through these indices because it needs by itself another lecture. But we have to know we have a way to assess or to make a change in the preload by heart-lung interaction to assess flow response through these modalities. But these modalities actually in ICU, we may face a difficulty to be applied in ICU. It needs all to be with sinus rhythm, normal volume cycled ventilations, tidal volume at least 8 ml per kg, heart rate, respiratory rate ratio, no patient ventilator dysynchrony, normal chest compliance, normal intra-abdominal pressure, and normal pulmonary compliance. Another way of fluid challenge assessment or change in preload by fluid challenge. Fluid challenge used mainly to stop fluid. As we know, we decide we go with conservative management of fluid. The only patient will get fluid is the fluid responders to avoid fluid overload, which increases mortality. So the target of fluid challenge to test this patient is already has a good volume, I will stop giving fluid. The disadvantages of fluid challenge that I give already fluid, I cannot remove it again. If patient already volume overload and I give fluid challenge, so he receives the fluid, becomes more overloaded. So to do fluid challenge, it requires also 3 points. We need to give volume within a time. We need to assess response, which should be through monitors. We have to avoid false interpretations. For volume within a time, we have to give volume crystalloid 4 ml per kg, or we may go with colloid, which is called mini fluid challenge, 100 ml per stat. Time should be within 10 to 15 minutes. Rapid administrations to avoid, because if you go slow administration of this fluid challenge, redistribution of this fluid, and it lost its effect as a fluid challenge, as a fluid bolus to the patient. We have to assess the response through increased MAP, decrease in heart rate, clinically, the increase in cardiac output and or stroke volume by 10%, or echo assessment, reasonable raise in the cardiac filling pressure. And we have to avoid false interpretation. Any stimulation of the patient, any change of the regimen of medication currently the patient is on, it may affect the result. So don't touch the patient, don't stimulate him, don't increase or add a new medication like vasopressor dose, don't increase the dose, don't start vasopressors and do fluid challenge. It may mislead you as an interpretation of fluid challenge. The third and last one to change in the preload is by fluid redistribution. Fluid redistribution through passive leg raise, lifting the leg passively from horizontal position, inducing a gravitational transfer of around 300 ml from the lower limbs towards the intrathoracic compartment. Passive leg raise is considered auto transfusion. It is reversible. It is different from fluid challenge. It is reversible. If I don't found my patient fluid responder, so if I just reversing its effect once the leg are tilted down again, so its effect is resolved and its effect is subsides. So it's considered auto transfusion and reversible. The Fear and Jane 2015 put 5 rules to do passive leg raise in a proper way. First, to start from the semi-recumbent and not from the supine position. Put the patient semi-recumbent first step. Must be assessed by direct measurement of the cardiac output and not by the simple measurement of the blood pressure. Passive leg raise, it will take time only 1 minute. It will vanish within 1 minute. So we need real-time monitoring of cardiac output. So echo, pulse contour analysis, esophageal Doppler, change in the exhaled end-tidal carbon dioxide. It may guide real-time monitoring of the cardiac output. Cardiac output must be measured during and after passive leg raise in order to check that it returns to its baseline. Again, like a fluid challenge, avoid false interpretation. Bronchial secretion, suction, stimulation of the patient, touching the patient by your hand and performing raising passive leg raise by your hand, it may stimulate the patient. It may falsely giving impression of increased cardiac output, while it is due to your stimulation and increased catecholamine by your stimulation. We have to know also fluid resuscitation in general. We are testing fluid responsiveness mainly. It makes sense only in circulatory failure. Keep in mind that none of these tests are 100% sensitive or specific. You have to keep your eyes on fluid balance. Under or over hydration, it may harm the patient. Dynamic blood pressure monitoring, tissue hyperfusion, lactate clearance, and the most important urine output also can be used as a monitor. With any new vital changes, please reassess your patient again. This is a very nice review, 2018, the principle of fluid management and stewardship in septic shock. It is time to consider 4Ds and 4 phases of fluid therapy. It's a very nice review. It deals with the fluid like a drug. We need 4Ds like a drug. What is the type of the drug you will use, duration, dosing, and de-escalation. We need also to manage fluid resuscitation as an ROSE concept. Start by resuscitation, optimization, stabilization, and evacuation. De-escalation and evacuation means all of them we are going to also conservative. We have to limit volume overload. They found a patient positive balance by day 3 in ICU, it increased mortality. So also this review.
Can you just get more quicker, just coming to a conclusion, please?
Sorry? Okay. Just give me 3 minutes only.
Okay, thank you.
So what type of fluid? Fluid mainly by evidence-based and the study found crystalloid-like colloid. But in subgroup analysis or meta-analysis, we found colloid is the best. But due to availability and the low and the higher cost, they are concerning and recommending crystalloid. This is a nice study also, SMART trial 2018. They mentioned we have 9 reasons to stop using normal saline and to go for use of ringer lactate. The 8 reasons, the first 8 reasons due to the harm effect of normal saline. The reason number 9, because it is a better option, we have ringer lactate is more important. Currently, we have two running studies, two big studies, basics study, which will finish in October 2020, and it will be expected to be discussed in next meeting 2021 in critical care meeting, inshallah. It is done in Brazil. In Australia, another study, the same, plasma lights versus normal saline, it will end by March 2021, and we're waiting the result. Finally, is the appropriate use of antibiotic, or you're applying vasopressors if hypotension during or after. Two, if a patient presented initially by hypotension, it carry twofold increased mortality. Our target management to reach a MAB is to restore organ function. We don't have target MAB is our management is not the MAB, the target. We need organ function. We need organ perfusion. So initially we need a MAB. This MAB should increase organ perfusion pressure or reach the target organ perfusion pressure, which will later on improve organ function. A target MAB per sepsis campaign more than or equal 65 millimeter MAB. But we may accept lower MAB, especially in patients we have cardiomyopathy, low ejection fraction, low contractility. We may accept MAB. We may accept a higher MAB in patients with hypertensive. It was increased the ICB, with increased the intra-abdominal pressure, with increased the CVB. All this one we are dealing with increased the organ perfusion. So our target is the organ perfusion pressure, not a MAB. Our target is the organ function, not a MAB. First, of course, the recent study 2020 recommend early use of vasopressor. It will improve outcome and decrease the burden of using volume overload. Alternative vasopressin is an aid to decrease the requirement of levofed, but alone as a monotherapy failed to show any improvement. Dopamine it is not recommended, but may be used in significant bradycardia. Angiotensin 2 is approved, but still we have limited study for using as an alternative as a vasopressors. Our 1 hour bundle practice, we face a problem regarding start, which 1 hour, from where we should starting time, from sepsis onset or from ER entrance, from diagnosis, from antibiotic order. Antibiotic within 1 hour. Till now in our hospital, we fail to give antibiotic within 1 hour from diagnosis. System problem, entering, approving, culture, everything. We fail to give within 1 hour. And this is a study 2019, they said they found no difference between giving antibiotic within 3 hours or within 1 hour. Lastly, lactate availability as a monitoring in all hospitals is not available all the time. I think our one bundle should be reviewed, maybe turn back to a 3 hour bundle, maybe more applicable. And take home message, despite best effort of protocol-based management, sepsis continue to be a significant healthcare issue. Early recognition and then intervention save lives. Till now, our one bundle is a recommended initial protocol of management. Delay or appropriate antibiotic will increase mortality. Not all shock patients will get benefit from giving fluid. You have to find the fluid responder, and resuscitation target is to achieve an adequate MAB and maintain organ perfusion pressure, which help restoration of organ function. Thanks a lot, and thanks for time.
Thank you, Dr. Hisham. Nice and attractive lecture, really, and updating and summarized. Thank you. We have some questions here, and I think routine questions in such cases of sepsis. What is the fluid you prefer, type of fluid you prefer, and if you give lactate, renal lactate, you don't afraid from increasing lactate level?
Actually, first of all, as per recommendation, the guideline and the study, and this, we said the smartest trial, it recommend mainly renal lactate. Normal saline carry a lot of mortality, a lot of drawbacks, hypercholemic metabolic acidosis, renal impairment, requiring renal dialysis. So the first choice currently, per evidence, is the renal lactate. Renal lactate does not contain lactate. It's bicarb. It is mainly metabolized in the liver and in the bicarb, and even it may improve the acid-base disorders of a patient with septic shock.
Right. About biomarkers and procalcitonin and lactate level, you depend on these biomarkers for giving antibiotic?
Yes, procalcitonin is now, yeah, 1 point we can cut point to 0.5, we can use it less than 0.5. It may not be considered as a bacterial infection, but we may have another, procalcitonin mainly used for bacterial infection. Cut point to 0.5, less than 0.5, we not consider bacterial infection. More than, we may consider adding starting antibiotic. And also it may be used for monitoring and follow-up. If decreased by 50 to 80% from the baseline after initiation of antibiotic, it may give us a clue that we are going in the right way. And even we may use it as to de-escalate antibiotic use also.
Another nice question.
For lactate, we have concern regarding lactate. We have many causes of lactate. Lactate is may be due to tissue hyperfusion. It may be you have another cause. We have to be clear with dealing with lactate as a source of hyperfusion. Maybe we have another causes, decrease the clearance, increased production. So we have to think for lactate first.
Yes, differentiation between dextro and levulactate, of course. About another question she asked about the leg raising. It is essential or mandatory to be automatic by bed red, or you suppose you have no automatic bed. You can raise manual, but you are afraid from, as you told,
simulation.
Explained from force interpretation. Yes.
Yes.
Mm-hmm.
So as the recommendation should be by automatic by the bed to avoid stimulation. If we have patient already deeply sedated and good analgesia, muscle relaxant, and you have a monitor of level of sedation like this monitor while he has muscle relaxant, you may use it by your hand if you don't have availability of the automatic bed.
About CRT and anti-inflammatory in cases of excessive pro-inflammatory state, you prefer to give as in cases of cytokine storm and so on? This is another question from Talat.
You mean CRT or?
CRT, yes, I think I asked about CRT and especially hemofiltration in such situations of severe sepsis.
Wallah, till now I don't have an evidence to use it to remove inflammatory markers, but I don't have actually an evidence.
If you allow me, really from our experience in ICU, it is very good and essential, especially in cases of severe inflammatory state. And even in other situations like heart failure and so on, it removes some of the cytokines and decreases the degree of sepsis, especially if you use continuous venous hemodialysis filtration. Sometimes use it for 2 days, 3 days, or even 1 week to tell the patient the hemodynamic state improves. Nice lecture, Dr. Hisham, and thanks for you and thanks for this nice presentation. And really very nice and very good and highly attractive. Thank you.
Thanks a lot. Thanks a lot.
Dr. Saad, you can shift to the next.
Dr. Muhammad Mahmoud is going to be next moderator. Dr. Muhammad. Your voice is not.
It's not clear.
Yeah, it's clear now. Good man. Thank you.
Thanks, Prof. Samir. Thanks, Dr. Saad. Thanks, Dr. All the panelists for this support and for that great day. Next speaker is going to be Dr. Adel Hussein. He's going to teach us in the next 30 minutes about antibiotic and sepsis, when, what, and how. Dr. Adel is a graduate from Cairo University in 1992. He's obtained his master's degree in 1997 from Cairo University. He completed his MD degree from Cairo University as well in 2002. He's a former assistant professor of critical care medicine, Cairo University, and he's currently working in critical care as a critical care consultant in King Abdullah Medical City in Mecca, Saudi Arabia. Please, Dr. Adel, feel free to.
Thank you. السلام عليكم ورحمة الله وبركاته. بسم الله الرحمن الرحيم. الحمد لله رب العالمين والصلاة والسلام على أشرف خلق الله والمرسلين سيدنا محمد وعلى آله وصحبه وسلم تسليما كثيرا. First of all, I have to appreciate and to thank Professor Saad Mahdi and his colleagues, the organizers, the moderators, all panelists, Professor Al-Ansari especially, for giving me this opportunity to be with you tonight. I hope my title will fit for the 30 minutes time frame. Though it's difficult to cover or to highlight the antibiotics in 30 minutes, but I will try my best. And please accept my apology if I skip some slides because of the time frame. So the title is for this presentation is the antibiotics in sepsis, when, what, and how. I have no relevant relationship with any commercial or non-profit organizations. This is the objectives of my presentation tonight. I will give just a short overview. First of all, then I will highlight the important pillars of the antibiotics coverage in sepsis. First is the appropriateness of empirical antimicrobial therapy. Second is how to achieve the goal of timely antibiotic administration. Third is the dose option. Fourth is the combination of antibiotic therapy in sepsis and septic shock. Fifth is the duration of antimicrobial therapy. Next is the de-escalation of the antimicrobial therapy. And lastly is the use of biomarkers to guide the antimicrobial therapy in sepsis. And I will sum up with some take-home messages. Let's do sepsis the problem. Of course, sepsis is a public health problem. It carries a high mortality. It comprises about 12% of total ICU admissions. And of course, in each country, its burden of death 3 times those of the national road toll. Commonly, we have sepsis pitfalls. So please, to increase the awareness, try to avoid the pitfalls. What's the common pitfalls is the failure of recognition, failure of early detection, underestimation or underappreciation of the ICU mortality, and also failure to respect the sepsis syndrome as time-critical illness. Of course, all of us working in trauma or CCU, we are neurocritical care. We have 3 codes for the hospital: trauma, trans to mortality. The overall mortality from trauma is about 7%. For STEMI, is about 5%. This is overall mortality. The stroke is about 8%. Okay, what about the septic shock mortality? Treble or quadruple, it's about 25%. So if you have a patient admitted alone with septic shock, not with multi-organ failure, not with ERDS, just for septic shock, it's about 25% mortality. So we are underappreciating, we are not having a septic code or sepsis code. What are the common reasons for litigation and sepsis care? And this is very common when you have a medico-legal issue regarding sepsis care or sepsis management. First is the failure to recognize sepsis, delay in management, like delay in triaging, nursing assessment, door to doctor, ancillary services. Those are results or can result in delayed treatment and bad outcome. Failure to aggressively resuscitate with the fluid, as Dr. Hisham said in his lecture, too little or too late or not at all. Failure to administer early, appropriate, and broad spectrum antibiotic, which is the core of my presentation tonight. Failure to consult the critical care team, failure to monitor and to treat the decompensation or the sequelae of sepsis, and lastly is the failure to admit to the appropriate level of care or failure to disposition to appropriate level of care. So if you ask me what are the challenges to standardize the sepsis management, this is a worldwide question, and this is one of the major concerns. Till now, you cannot standardize the sepsis syndrome management. Why? Your patient is having multiple comorbidities, plus the infection, the immune response, the physiologic derangement that results from those sequelae, and overall, or the sequelae of organ dysfunction. So those challenges led to unavailable standardization in the sepsis management. Yes, you have the best available evidence, but till now you have those challenges you cannot overcome one by one. As Dr. Hisham said, I will not go through. This is the 1 hour model, the common diagram for initial resuscitation and septic shock. It's a very famous one from Surviving Sepsis Campaign. This is the components. I will not go through also. Just quickly reminder, and for someone of the attendees was asking about the critical lactate level, is the lactate more or equal than 4. So this is your target, and you re-measure if the initial lactate was more than 2. But for you and the 1 hour bundle, your cutoff is more or equal to 4. So the messages from the Surviving Sepsis Campaign, as all we know, just I would like to highlight those 4 pillars that you should actively upon sepsis recognition. So time is counting. Second, you have to minimize time to treatment in sepsis and septic shock, because both of them, we call it medical emergencies. So you should behave the same like you are behaving in the trauma or the STEMI or the stroke. Third, you should monitor closely for response to intervention. And fourth, you should communicate the sepsis status in hands off for your colleagues and for the multidisciplinary team. If I will highlight the initial resuscitation hour 1 bundle, as Dr. Hisham said, I will not go through all components, but just to highlight for those 5 components, it's like a bundle. You should not ignore one. You should use it as a bundle. So measuring lactate, blood cultures before the antibiotics, giving the broad spectrum antibiotics, giving the IV crystalloids when indicated, use of vasopressors when indicated, and end up with reperfusion assessment, which is it's very important. So my core tonight is about the broad spectrum antibiotics in sepsis and septic shock. So before moving antibiotic or the blood culture, Hisham already said, just I would like to add this slide. Why usually we recommend, or the Surviving Sepsis Campaign recommend 2 sets of blood cultures. First is because of the incorporation of matching sets. It confirmed the treatment of true pathogen, not a contaminant. This is why we use 2 sets, not 1 set. The goal is to prevent culture negative sepsis and septic shock. Out of 6.8 or 7 million septic shock admissions, almost close to 47 to 50% were culture negative. So you can imagine about 50% of sepsis, septic shock, they are culture negative. So culture negative sepsis, septic shock was seen as statistically significant independent predictor of death. So remember this very well, about 50% of your patients are culture negative, and adding to this, they are independent. This is independent predictor of death. So if you have patient with septic shock and you hosted your cultures survey, then you end up with culture negative septic shock. This is a significant predictor of mortality. And measuring the hour 1 bundle is very important to know where you are standing. Are you succeeding? Are you compliant with the 1 hour bundle? So this is a study measuring the sepsis core measures and why they fail to be compliant, and where it is the components of failure. So here is the lactate measurement, repetition. Here is the fluid administration less than 30, antibiotic administration more than 2 hours, lactate result in more than 3 hours, blood culture drawn more than 3 hours. So this is the failure of the sepsis score measures analysis. This is your rule when you apply, just not to apply, just to monitor your sepsis score measures, when you succeed, when you fail, and why you fail, and what mainly component. Is it the blood culture? Is it the antibiotic delay? So this is very important when you monitor with your quality or with the administration the sepsis score measures. Do really the minutes matter in sepsis resuscitation? Is it really important? To answer this question, the Society of Critical Care Medicine published a retrospective cohort study about 5,000 patients in severe sepsis, septic shock. Majority of patients had the 3 hours bundle recommendation, the before version, the previous version, initiated within 3 hours before 2016. In hospital mortality was 27% with those people who applied or they were compliant with the 3 hour bundle recommendation. But they analyzed the time frame from within the 3 hour bundles and what are the components. We call it sepsis score measures. So the time after which the delay, they found that there was an increased risk of this. Lactate reached 20 minutes to get it. Blood culture, 50 minutes, close to 1 hour to get it. Antibiotics exceeded 2 hours, and giving the crystalloids, the appropriate IV fluids, exceeded 1 hour. So the guidelines recommendation showed that shorter delays indicate better outcome. Why? Because minutes matter. There was no evidence that 3 hours is safe. Even very short delay adversely impact the outcome. The antibiotics, as all we know, are the life-saving treatment in sepsis and are the single most effective treatment we have for sepsis and septic shock. The longer treatment is delayed with giving the antibiotics, the higher the patient risk for mortality rises, of course. And since 2001, 2006, from Kumar et al., which was the classic study that we rely on the timing of antibiotics in septic shock, every 1 hour antibiotic initiation is delayed. This is, of course, increases the risk of mortality up to 8%. Antibiotics in sepsis and septic shock, like everything else in life, timing is everything. And this is a graph that translates what we said, that for every 1 hour delay in antibiotics, there is an increase of mortality up to 8%. So the most important thing you can do for your septic patient is do not delay the antibiotic administration. And this is a study also since 2000, a famous one from 2007. It correlates the early initiation of appropriate antibiotic therapy in septic shock and its relation to survival. And here, as we can see, the relation between the the overall survival correlated to the early antibiotic administration. The delay in antibiotic administration is increased with a mortality rate and lower survival rate. So every time you delay the antibiotics, here you give it at 1 hour, here you give it at 12 hours antibiotic, for example, or here at 6 hours, for example. So the survival rate is, the mortality rate is increasing as far as you are delaying the antibiotics. Also another translation, this is the delay of antibiotics of the first dose in sepsis and septic shock, and this is correlates with increasing mortality up to 45 to 50%. Antibiotics should be given as soon as possible, but when? After blood cultures are drawn, preferably after the second set of cultures. This is usually what we recommend. So usually give the antibiotics after blood culture, so do not delay the blood cultures. Try not to delay. Preferably, you give the antibiotics after the second set of cultures. However, if the second set is going to be delayed more than 30 minutes, antibiotics should be started after the first. This is an exception. If more than one antibiotics is ordered, like you use combination of antibiotics, give the broadest spectrum antibiotic first. For example, if you're going to use one of the beta-lactams or one of the carbapenem, so this should be given first. and infuse multiple antibiotics concurrently if appropriate. Always give the antibiotics with the shortest run time first without delay. Give the antibiotics with 30 minutes infusion time at first, like STAT. So STAT definition, less than 30 minutes, the antibiotics should be given. Then give the one that is infused over 1 or 2 hours infusions. So for example, if I'm gonna use vancomycin, you cannot give it a short run, not a bolus, but you have to give it as infusion. But for other antibiotics, yes, you can use it, the STAT one as push and with the shortest run time first. Give the first dose. This is very important, and we face it many times in the ER or in the ICU that the patient has renal failure or chronic liver disease, and we are adjusting the first dose. No, the first dose usually, even if it's an end-stage disease, chronic liver disease, does not need an adjustment. Give it full dose. For example, Beptazo, give it 4.5 from as a full dose without dose adjustment. Then adjust later on. For meropenem, you're gonna use 1 gram or 2 gram. Give it the full dose from the start without adjustment. Then adjust from the next dose based on the creatinine clearance or the liver functions. So how long does it really take to administer the antibiotics? Yes, they studied this, and there was 3 RCTs, the ARISE, the PROCESS, PROMIS. All of you know about it. The median delay of the antibiotics from arrival in the ED to ER, not from the diagnosis of sepsis. This is a very controversial point, which you want to calculate from arrival to ER or from sepsis diagnosis. Better or evidence-based wise is from sepsis diagnosis. So here in those are the 3 major RCTs. The median here was about 70 minutes. With the PROCESS trial, was majority within 3 hours. With the PROMIS trial, the majority with the median was about 2.5 hours. All of us, we know what's the rationale behind giving early antibiotics. I will put the slide, but I will not go into details. But usually the mortality is not necessary. What is important to mention here is the mortality is not necessarily caused by infection itself, but the physiological response to infection and multi-organ dysfunction is very important to know about it. And your early antibiotics is to help or to ameliorate this physiological progression to multi-organ failure syndrome. If you want to dissect what are the common reasons behind antibiotics delay in the ER or in the ICU or in the floor when you assess, for example, RRT or SAT team or sepsis code. So we found that there is system level factors. We found patient level factors, and we realized about presentation level factors. For system level factors, ER crowding, inadequate staffing, as Dr. Sherman before in his presentation, delays in diagnostic testing, patient transfer, internal policies that interfere with early administration of antibiotics, like anti-stewardship program or approval from IDT. Those are system level factors. What are the patient level factors? The age and the comorbid condition that predispose patient to having atypical presentation, like in elderly people, immune compromised. So there was atypical presentation that's underdiagnosed or underestimate the presence of sepsis and delaying, of course, antibiotics. History of drug reactions, difficult IV access, those related to the patient himself or the host. What about the presentation level factors? The atypical presentation, of course, like, as we mentioned before, like in elderly people, like in immune compromised, the atypical presentation leads to delayed diagnosis. The evolution, we call it the evolution of clinical symptoms, signs and symptoms, the ability to recognize clinical features, the requirement for further diagnostic tests like imaging. The goal everywhere in the ER or in the floor or in ICU is to stop the infection, but antibiotics alone are not enough. Source control has pivotal role in sepsis management. It is something need the core of 4 Ds of source control. So please do not delay. I will not go quickly for this because my colleague, Professor Hassam Afifi, he will highlight probably, and you will enjoy how he will address the source control. So for the antibiotics, the appropriate antibiotics, yes, are essential. But until the organism is identified, broad spectrum antibiotic treatment is necessary to cover most likely the sources. Source control usually is the key to stop inflammatory response and the cascade of the systemic dysregulation. So the core of source control, 4Ds. Every time you face patient with sepsis, septic shock, confirm a diagnosis, ask yourself about the 4Ds. Drainage for any collection or loculation, debridement for any soft tissue infection, device removal for any lines, central line, big line, permecath, and definitive measures for surgical intervention if you have bowel ischemia, perforated viscous. So those are the 4Ds for source control. And remember the mantra. The mantra for timing of antibiotics for sepsis is to hit 3 hard, early, and appropriately. And this is the therapeutic ladder of antibiotics in sepsis: the appropriate therapy, the adequate therapy using the timing, the penetration, the pharmacokinetics and pharmacodynamics, and the optimal therapy. Then how to reach the optimal antibiotic therapy? Through when, what, and how. So optimal antibiotic therapy, you should have adequate timing. This is when to start. Then adequate duration, when to stop. Then what's the adequate coverage? What organisms you're gonna cover? This is what. What's the correct route? So this is BO or IV. Of course, for septic patient, you are relying on IV. So this is how. For what the correct dose and pharmacokinetics and pharmacodynamics that affect your antibiotics, this is how much. What is the correct administration, prolonged infusion, extended infusion, this is how. And what are the immunomodulatory effects? Those are the components that determine the optimal antibiotic therapy. For the antibiotic therapy timing, so this study in 2014 published in the Critical Care Medicine Journal. So the conclusion of this study that the analysis of large population with sepsis or septic shock demonstrate that delaying the first antibiotic administration was associated with hospitality. In addition, there was a linear increase of risk of mortality to each 1 hour delay of antibiotic administration. There is results of underscoring the importance of early identification and treatment of septic shock and awareness in the hospital settings. Also, you need to have an evidence. A lot of evidence are accumulating since long time. A patient with severe septic shock, he should receive early and appropriate antibiotics in the ER or in the floor if you are managing the rapid response team. Patient with septic shock who received the appropriate microbial therapy within 1 hour for ignition had greatest benefit in mortality. As Dr. Hisham said, that there is a Belton et al. In 2019 reported that there is no mortality benefit of administering antibiotics within hour. Of course, this was a study published in 2019, but there is a lot of criticism for those data in 2017 and also one in 2020 regarding the study design, regarding the antibiotic administration appropriately and the non-infectious source, as Dr. Sham said. Regarding the pharmacokinetics and pharmacodynamics, those are usually the physiologic alterations that usually affect the pharmacokinetics and pharmacodynamics of the antibiotics in sepsis. So in sepsis, usually the volume of resuscitation, the capillary leak syndrome, the hypoalbuminemia, those lead to increase the volume of distribution. For sepsis, because of the hyperdynamic circulation, we have high cardiac output status. This elevates the clearance of the antibiotics and medications. This is, of course, combined with the capillary leak, the hypomania, with the increased distribution, it will lead to low plasma concentration. So you have to be aware about this. On the other hand, if you have sepsis, septic shock with its sequelae, which is the organ dysfunction, renal failure, liver failure, this is, of course, will decrease the clearance and, of course, will lead to high plasma concentration. This is the effect of administering meropenem with different routes, like with different protocols, intermittent infusion, prolonged infusion, or continuous infusion. If you look here, the lowest required dose to reach the 2 milligram per liter for volume distribution, it was the best with the continuous infusion. Intermediately was with prolonged infusion, but here with intermittent, you need 4 to 6 grams to reach the lowest dose, or when we reach the MIC or battery MIC. So better with prolonged infusion, much better with continuous infusion. I will just skip those slides about, though it's important, about the augmented renal clearance. So what does it mean if you are in doubt about MDRO's organisms as the most likely of the sepsis, and you have a normal or high renal clearance? So here you hit with stents, or you want to broader. If you have a nice resistant pattern of antibiogram, patients have renal function start decline, so you have to decline or to narrow your antibiotics. They demonstrated in this study the demographic, antibiotic, and illness severity for those with augmented renal clearance, and they found those patients usually are young males with normal serum creatinine. What's the effect of obesity on population? Pharmacokinetics and pharmacodynamics of meropenem administration critically ill. Obesity, it increased the volume of distribution. Of course, it affects the PK/PD parameters. But they found, although the obesity was found to be associated with increased volume of distribution, dose adjustment and creatinine clearance appears to be important more than the PMI. So again, you have to address and to respect and appreciate the creatinine clearance and augmented creatinine clearance. This is the pattern how important is using the loading dose. If, for example, if you are using antibiotics like meropenem or colistin, so for effective concentration, the loading dose usually is not affected by renal function as a stat dose. So this is very important when you are giving a drug, or antibiotic like colistin. You have to use the full loading dose, like 9 millions or more. This is a nice meta-analysis. It compared the continuous versus the intermittent beta-lactam infusion in severe sepsis. And here it is translated into a favorable outcome for both in-hospital and ICU mortality with the continuous infusion. While here is the mortality Kaplan-Meier curve shows the 30 days mortality reduction with using the continuous infusion of antibiotics compared to the intermittent. So they concluded that compared with the intermittent dosing, administration of beta-lactams antibiotics by continuous infusion in critically ill patients with severe sepsis, septic shock is associated with decreased hospital mortality. There is an ongoing trial called the BLINK-3 trial. This is an ongoing prospective, multi-center, open label, phase 3 RCT. They are comparing the meropenem or bebtezo in intermittent or continuous infusion. What they are aiming for, they are comparing the effect of the 90-day mortality, beta-lactams, antibiotics, bebtezo, and meropenem, administered either continuous or intermittent infusion in a large patient population, about 7,000 critical ill patients with sepsis. It's not published yet because it's still an ongoing trial. What about the therapeutic drug monitoring? Just is not the core of my lecture tonight, but just to brainstorm you when you go back about the TDM. How many of you perform TDM of beta lactams, which is very important part of research, part for clinical practice? And still, do we need RCT? I agree. So to conclude with this, start antibiotics early. We likely never have a definitive evidence. Start with loading dose. If no doubt on MDROs or high renal clearance, normal renal clearance, I mean, aim for higher than normal dose. If you can, monitor what you are doing, which is very important, and adjust according to that. Evaluate and stop antibiotics time. What about the advantage? The other part or the other pillar of the optimal antibiotic therapy, adequate coverage. Should we appreciate the problem magnitude? Yes, we should appreciate it. Why? Because the prescription of inadequate empiric antibiotic therapy is prevailing. The incidence is up to 40% of cases they are not receiving adequate empiric antibiotic therapy. Depending on the incidence of MDROs, pathogens, and the degree of adherence to clinical guidelines, the coexistence of delay and efficacy of the treatment has been associated with low survival rate. This is, of course, because you are delaying the antibiotics. And here is worldwide, up to 40% of cases of patients with septic shock in the ER or the rapid response or the ward or in the ICU, 40% of they are not using, they are not receiving adequate empiric wide spectrum antibiotic therapy. For many reasons, as we mentioned before. So how to select an adequate empirical antimicrobial therapy? Adequate is to cover all likely microorganisms causing suspected source of infection. So if you are facing patient or host that is immune compromised, you should think about your antibiotics to cover the most likely organisms. We group it into three major important factors that can help to use or to choose adequately the empiric antimicrobial therapy in sepsis. Patient-related factors, pathogen-related factors, and local antibiogram chart. Patient-related factors, age, weight, allergies, the comorbidities, the underlying chronic organ dysfunction like renal failure, liver failure, immunosuppressive therapy, and history of recent exposure to antimicrobials. For pathogen factors, the risk of multi-drug organisms or the risk for invasive fungal infection. So you should review your patient about prior antibiotic exposure, prolonged hospital stay, recent hospitalization, the presence of lines, invasive lines, local ecology and resistance, which is related to local histobiogram, and the previous colonization by resistant pathogen. This is from your surveillance cultures. And finally, you should have your own local antibiogram at your hospital and review it every time, every quarter, every 6 months, every 1 year. It depends about your local antibiogram at your unit. So those are the steps usually when you gonna use antibiotics in sepsis to hit hard and appropriate. Think about hospital factors related to the patient, as you mentioned. What are the clinical syndrome you are treated? It's soft tissue infection, it's abdominal sepsis, is a meningitis. What are the most likely organisms involved? It is MRSA, it's MDROs, it's gram-negative. What are the risks factor for resistant organisms, as we mentioned before? Reviewing the BD key factors, pharmacodynamics, obesity, if the patient on RRT, on ECMO, so it's very important. At the end, you should use the antibiotic according to those 5 pillars. Also, one part of your job is to know the coverage. Who is covering gram-positive? Who is covering gram-negative? Who is covering anaerobes? And who is overlapping? And this is for each time you have to refer to your patient and local sensitivities, which is the local antibiogram. Combination or monoantibiotic therapy. Also, this is very important but I will highlight because the combination therapy is defined as use of two different classes of antibiotics with activity against a single pathogen, mainly for two reasons: to accelerate pathogen clearance and to warrant pathogen susceptibility to treatment. What is the advantage, theoretical advantage of combination therapy? Broader empirical coverage, synergistic effect, decrease the risk of resistance. But what are the theoretical disadvantages of using combination therapy? Increase the risk of toxicity, renal failure or liver failure, increase the exposure of antibiotics, also driving resistance, collateral damage to commensal flora, and of course, increase, okay, just 3 minutes. And increase the, of course, the cost. The best available evidence in ICU patients, this is regarding the combination therapy. The duration, the shorter duration of antibiotics, of course, prolonged duration of antibiotic therapy is associated with increased resistance. Disregard the special situation like endocarditis or gram-negative meningitis, stomatitis. Prolonged antibiotic therapy has not been demonstrated to be beneficial. We have a lot of evidence, 2013, 15, 18, that shorter antibiotics is the best. This is what the literature said. And we need to individualize the duration of antibiotic therapy, yes, because the severity of illness and clinical response, type of infection, deep-seated or MDRO's coverage, of course, source control, availability of the diagnostic tools like clinical and clinical scores and biomarkers, the escalation of the antibiotics, meaning going the empirical antibiotic therapy to the tailored therapy, is considered essential to have a successful antibiotic stewardship program. And usually this de-escalation practice, it focuses on reducing the antimicrobial resistance and the adverse related effect. And also we have an evidence base that de-escalation therapy is one of the safest and effective practice in managing the septic shock. It is estimated that in US, Europe, about 11 to 55% of treatment are de-escalated only, so about 50% still they are non-compliant. The main barriers for de-escalation practice: fear of patient deterioration, fear of patient being colonized with other organisms, facing management struggling when the patient have culture negative sepsis, and the lack of local policy or local guidelines. Biomarkers, just all of us, we know about the role of procalcitonin, but the problem with the procalcitonin, yes, it's more specific than CRP, but the beneficial effect of PCT-based algorithms have been demonstrated in critically ill patients. Also the CRB, but in most cases of septic shock, PCT level, as Dr. Hisham said, less than 0.5 or decreased by 80% of the highest BCT level has been observed to have a useful support in the clinical decision of stopping antibiotics, while also predicting favorable outcome. But again,
time,
yes,
please.
Okay.
Time, please.
So just to have some take-home messages with the next 3 slides, the only definitive treatment for sepsis is antibiotics. All other intervention guide treatment are supportive care. There are no linear correlation between mortality and time to antibiotics, as we mentioned. It's still debatable. The longer it takes to get antibiotics patient sepsis, the higher their risk of mortality and morbidity. The risk of mortality for someone who progresses for septic shock is upward up to 50%. And remember, the mortality risk goes up to 8% for each antibiotics delay. Give them early and broader. Initial broader antibiotics should be followed by rapid, responsible de-escalation. As long as the causative pathogen is covered with a single empirical therapy, additional agents will not give any additional benefit. Optimizing the antibiotic use to improve the patient outcome, optimize the antibiotic use to minimize the pressure on emerging antibiotic resistance. And this is the final slide, just reminding you about the 5 pillars helping you in choosing the antibiotics: the patient-related factors, the clinical syndrome, and the most likely organisms, the risk of resistance, and PDB. And thank you, and sorry for delay.
Thanks very much, Prof. Adel, for this informative lecture. It's very wealthy, enriched with evidence-based medicine, included a lot of physiological, pharmacological, as well as pathophysiological data, which we should all at least test and intensivist get back to when dealing with our patient. Thanks for introducing the matter of the minutes matter. You highlighted it very well. Just because we're running a bit late, so we're going to take only 2 questions. So, so 2 questions here is about de-escalation of antibiotic, especially with multi-drug resistant, and another question that's a bit related is as well as with implementation of antibiotic stewardship. Should it be applicable in all institutions? In UK, for example, there is a discussion between micro and intensivist. Should be the case with each hospital? It should be a discussion individualized for each patient. So just to highlight these 2 questions as possible, please, and we move to the next lecture after that. Yeah.
Thank you, Dr. Mohammed. For the first question regarding the MDRO's coverage, yes, this is one of the fears usually when we start the practice of de-escalation, that for how long should I continue the antibiotics? On one side, that shortest is the best, like the practice 7 to 10 days. On the other hand, this is a multi-drug resistant. Once I de-escalate, the patient will crash or the patient became more colonized. So now the recommendation usually it comes, or the best available evidence when we have a multi-drug resistant or MDROs or XDROs, now they are extending up to from 10 days to 2 weeks, not 7 days. This is based on the clinical condition of the patient, the clinical response, more important than the biomarkers, more important than other factors. So that you are bedside and you are the one who can judge this patient is improving or not. So you can extend again those guidelines or those recommendations just guiding you. But if your patient is not improving, just you have to revisit again your source control. You have to readmit the BD key, the dose optimization, all the pillars of your antibiotic choice. This is mainly for MDROs. It's not simple like or just covering surgical prophylaxis. Is MDROs usually, or XDRs or BDRs usually, one of our nightmares in the ICU. Second question is regarding the ESP or the anti-short. I agree with you. Usually in our hospital, we had this practice like for more than 5 years. It's very successful in reducing the resistance and very successful in giving the antibiotics early. This team usually is very effective to manage patient, usually in the ER, RRT, and ICU. As you mentioned, Dr. Mohammed, that it's a team, it's a multi-professional ICU, clinical pharmacist, microbiologist, and infectious disease. And they published last year in 2019 or KMC a very interesting cost reduction regarding the empiric use of broad-spectrum antibiotics and antifungal, and it will reduce the cost by almost $300,000 US in 1 year.
Not here.
Mohammed.
Hello, sorry.
Yeah.
So thanks, Prof. Adil, and now we're going to move to the next lecture. So we're going to introduce Dr. Sarawat Isa. Dr. Sarawat has worked in 3 different healthcare systems, Egypt, Saudi Arabia, and Ireland. He obtained his master degree from Tanta University 2006 and completed his MD degree in 2015. He successfully passed the European diploma in intensive care in 2012 and completed the European diploma anesthesia and intensive care in 2018. He's currently working in one of the hospitals in Ireland, RCSI, Lewis Hospital Group. Dr. Sarawat is going to speak to us and in the next 30 minutes, including question about early goal-directed therapy and the trial. Please go ahead, Dr. Sarawat. Thank you.
Thank you, Muhammad, for the introduction, and I am really delighted tonight to be between my professors and seniors, Professor Dr. Adel, Dr. Hisham, and Dr. Afifi. This is my KMC family. And of course, I would like to thank Dr. Saad and the organizing committee, Dr. Ansari, for having me tonight among those eminent speakers. And I think my talk today will be a base of the cake, and I promise I will not exceed the time limit. It's going to be a short lecture about the AGDT, or the early goal directed therapy, and the TRIO. TRIO are the three trials, the three famous trials who are recommending the traditional therapy against the early goal directed therapy. And of course, you know, those guys, those are the European Society of Intensive Care Medicine and American Society of Critical Care Medicine. They gather together and they turned the world upside down earlier in 2015 because they represented the radical departure from the prior sepsis definition, sepsis 1, sepsis 2, and of course, we are now in sepsis 3. I will not go through this because already highlighted by Dr. Hisham in the first lecture about the sepsis definition and septic shock definition and associated mortality. So what is the history of AGDT, or the early goal directed therapy? Because before 2001, where the time of application of the early goal directed therapy, there was no standard of care for early management of septic patients, either severe sepsis or septic shock in the emergency department. And the mortality was that much quite high, 40 to 50%. In response to that, the AGDT collaborative group challenged the paradigm of sepsis care as an ICU emergency by applying a protocolized approach for the management of septic patients as early as possible, the same like or extrapolation from the management of MI, stroke patients and trauma patients on the presentation to the emergency department. And you guys know this man. This is a very famous doctor. This is River Doctor. Dr. Rivers is an emergency and critical care physician in the US. And he is the owner of the most famous trial in sepsis, and what we were following for almost 10 years before, based on the recommendations of the Surviving Sepsis Campaign. His famous trial, Early Goal-Directed Therapy in the Treatment of Severe Sepsis and Septic Shock, that is published in 2001. And it is a small, unblinded, single-center trial. He recruited 288 patients in the trial. And the main finding was the mortality reduction. There was a significant reduction in the mortality for the patients who are treated according to his protocol, which is the AGDT protocol. The reduction of mortality from 49% to 33%. And based on these findings, the recommendation of the major critical care societies worldwide came out by recommending early goal-directed therapy based on Rivers protocol. And it was the basis for 6-hour resuscitation bundle of Surviving Sepsis Campaign guidelines in 2004, 8, and 12. After that, there is a lot of concerns regarding the scientific basis of the study and the conduct of analysis. And this is the famous AGDT protocol. As you can see, starting by giving oxygen to the hypoxic patients, plus minus intubation ventilation. And of course, you have to insert a central line, arterial line. And if your patient is intubated, sedate and paralyze the patient, or both according to the situation of the patient. Your target CVB is 8 to 12 millimeter of mercury by giving crystalloids or colloids to achieve a target mean blood pressure of 65 plus. If not, you are gonna use vasoactive medications, norepinephrine or whatever, to achieve the target MAB. If you achieve the target MAB, measure the mixed venous oxygen saturation, central venous oxygen saturation, I mean. If it's below 70, so transfuse your patient to a hematocrit of 30 plus. If it is above 30, so you achieve the goals. So that was the stepwise protocol of Rivers. And the protocol, of course, was recommended by the Surviving Sepsis Campaign, but you can see it is impossible to tease out which intervention in this protocol made the most significant impact on the mortality. Is it the fluid boluses? Is it the MAP? Is it the transfusion? Is it the inotropic support that you can use if the patient has mixed venous below 70, or what? Or a combination of all together? So the components of AGDT have been a matter of controversy, specifically after the TRIC trial, this is famous trial comparing the restrictive versus liberal transfusion strategy for the critically ill patients with the target hemoglobin. AM SHOCKNET trial, that is the lactate clearance versus central venous oxygen saturation as a goal for early sepsis therapy as an endpoint for resuscitation. And of course, CVB has been known to be a poor surrogate for the blood volume in critically ill patients. Moreover, the study population limited to the emergency department presentations only. He didn't enroll any patients from the ward or the critically ill patients. So there was a lot of criticism to Rivers, and there, I think after this, all criticism, the river starts to get dry. And after that, the first trial of the trial came out in early March 2014, and it is a randomized trial of protocolized based critical care based care for early septic patients, or the process trial. It is a US trial, and the clinical question was, in adult patients with septic shock, does early goal-directed therapy compared with standard therapy reduce mortality at 6 days or not? It was a big trial, randomized controlled trial, non-blinded design. They screened more than 12,000 patients, and they enrolled a big number of them, 1,351. And the intervention was three arms in this study. One arm is Rivers protocol, the early goal-directed therapy for the 6 hours bundle with a dedicated physician, nurse, and research assistant for the prompts of the trial, and another arm for a protocol-based standard therapy based on the published expert opinions for the first 6 hours with dedicated physician, nurse, and research assistant as well. And the third arm is the usual care, no extra staffing, care by bedside physician for 6 hours, research assistant only to collect the data, and provides no prompting at all. So that was the outcome. The primary outcome was the mortality, and there was no difference at all in the mortality at 60 days between the three groups: early goal-directed therapy, protocol-based standard therapy, or the usual care. And also in the secondary outcomes, there was no difference in mortality, as you can see here, at 60 days or even at 90 days. So they concluded that no significant advantage with respect to mortality or morbidity of protocol-based resuscitation over the bedside care. The second nail in the coffin of Rivers was the second of the trial, which is ARISE. It is the Australian resuscitation in sepsis evaluation, and it is also an RCT published also in New England Journal of Medicine in October 2014, the same year of process trial, and almost the same clinical question, and it's comparing between early goal-directed therapy and usual care. Does it improve the mortality or not at 90 days? It is also a multi-center RCT. They recruited a big number of patients, and the follow-up at 90 days was intention to treat analysis. And the intervention here also almost the same of the process, AGDT as per Rivers trial, or usual care. And the usual care, RT line and CVC might be inserted, might not be inserted. So according to the clinical appropriateness, and the mixed venous oxygen saturation was not measured during the first 6 hours of intervention. And the outcome, primary outcome, was the all-cause mortality at 90 days. And the secondary outcome was the duration of stay, ICU, ED, and hospital length of stay. And there was no difference in the length of stay between both groups. Invasive ventilation, vasopressor requirements, RRTs, there was no difference at all between the AGDT or the usual care. Tertiary outcome was the all-cause mortality at 28 days and at ICU discharge 60 days. As you can see in this graph, there is no difference in mortality at 30 days, 60 or 90 days. So the third of the trial is the PROMISE trial. The PROMISE trial is the UK trial and is published in 2015 in March. And the same clinical question, does the early goal-directed therapy compared with the standard therapy reduce mortality at 90 days or not? It was a multi-center randomized trial also in 56 hospitals in UK over 3 years, and they enrolled more than 1,200 patients. Sorry. The intervention also here is a comparison between the early goal-directed therapy as per Rivers protocol with continuous monitoring of the mixed venous oxygen saturation as an endpoint for resuscitation versus the usual care, which was the control group. Arterial line, central line may be inserted if considered clinically appropriate. Mixed venous oxygen saturation was not measured in the first 6 hours, and decisions about the location of care delivery, investigations, monitoring, and all treatments made based on the clinical situation but by the bedside physician. The primary outcome, as you can see here, was the mortality, and you can see that there is no difference at all in the mortality between both groups, the AGDT versus the usual care. And the secondary outcome as well, length of ICU stay, both way, and also the outcome was SOFA score at 6 hours, and both were lower in the usual care group. So as a bottom line for the 3 trials, PROMISE, ARISE, and the PROCESS have shown no benefit or harm with early goal-directed therapy over usual care, unlike RIVERS 1. So, do we continue with AGDT or not? Or this is the end of the road? This is a nice editorial published in the New England Journal of Medicine. And after that, in 2015, there is a meta-analysis included the 3 trials and plus RIVER plus another trial of June's to compare the early goal-directed therapy versus the traditional therapy. And in this meta-analysis, you can see here that the early goal-directed therapy is not superior to the usual care for ED patients with septic shock, but it is associated with increased utilization of ICU resources. Another meta-analysis in 2017 included the 3 trials, plus RIVER, plus some trials. They also included that early goal-directed therapy didn't result in better outcome than usual care and was associated with higher hospitalization costs across a broad range of patients and the hospital characteristic. So there is some limitations to the PROCESS, ARISE, and the PROMISE, and caveats, yes, because all the trials used some elements of the early of the RIVERS protocol, which is the fluid resuscitation. They given the patient prior to randomization 30 ml per kg of fluids. So there was some precautions in the interpretation of the trials. But what? Do you think, guys, that the RIVERS got lost and it's getting dry or not? Let's see. There is always something is working here in this trial, in this study published in the JAMA in 2014. They studied the annual mortality in patients with severe sepsis. You can see here between 2000 and 2012, that the mortality decreased from 35% to 19% over 10 years. That is almost 1% per year in Australia and New Zealand, and 1 to 1.9% per year in the US. Those are the owners of the trials, right? So surviving sepsis campaign started to respond to the trials in sequence in 2014 after the process trial has been published. They stated that all groups in the study received an average of 2 liters of fluids prior to randomization, and 75% of patients in the process received before randomization antibiotics based on what? Based on the 3-hour surviving sepsis campaign bundles. And also the low mortality rate in the control arm of the process, which is the usual care, and the pending results of the ARISE and the PROMISE. Based on that, the surviving sepsis campaign didn't change their protocol of management, and they preferred to wait for the other trials. Moreover, they commented on the process that they didn't address repeating lactate as an endpoint for resuscitation, while literature supports that. So after the process and ARISE trial, again, they commented on the ARISE trial that they haven't demonstrated any adverse outcome in the groups that utilize CVB and central venous oxygen saturation as endpoints for resuscitation. Therefore, the surviving sepsis campaign said that there is no harm in existence and in keeping their bundle as it is without any adjustment, and they waited for the third trial. So in 2015, they started to change their mind after the results of the PROMISE trial, and they mentioned that as long as patients have received timely antibiotics and fluid resuscitation, the campaign said requiring a measurement of CVB and mixed venous oxygen saturation in all patients is not supported by the available evidence. As the results of PROMISE are in line with the results of PROCESS and ARISE studies, the hemodynamic bundle will be revised soon. This re-evaluation by the surviving sepsis campaign currently underway. And finally, they give us the first hour bundle, which is discussed already in the previous lectures. So you take a home message, guys, from this few minutes that sepsis is a dynamic syndrome with a lot of variables, either laboratory or clinical variables. And the most important to put in your mind that early recognition, early source control, early antimicrobial therapy, and fluid resuscitation, early escalation of antibiotics remains the fundamental treatment goals. And thank you.
Thanks very much, Dr. Farhat Isa, for that very informative lecture. It's not only to remind us about clinical and basic facts on dealing with the patient, but also remind us that we should stick to research. We should follow the evidence-based medicine, and we should do as much research and read as much research as we could, just to support our practice. Because there is no room at the moment in our current practice to just because I've done it, it works. No, you have to go back to the evidence and follow it. So so looking at the questions, Dr. Farhat, what is the new guidelines for normal saline bolus in children, or for any panelists?
Sorry, Mohammed, normal saline bolus, it's recommended 30 ml per kg. And some national guidelines advise to give 500 boluses every 15 minutes and reassess your patient. So one size not fits all in this scenario. You have to reassess your patient every bolus you are giving, and reassess your patient clinically and by biomarkers as well, mixed venous oxygen saturation, lactate. You are using the echo filling pressures, and you are using your ultrasound, so go thoroughly through the parameters, either static or dynamic parameters, and to achieve the endpoints for resuscitation.
I think this is the only question. Thanks very much, Dr. Sarawat, for that informative lecture. Now we're going to move on to our final lecture. So it's a privilege to welcome Dr. Prof. Hussam Afifi, who is going to speak to us about how to optimize source control. So Prof. Hussam Afifi has obtained his master degree in anesthesia and critical care in 2001. He successfully completed his PhD degree in 2006. And he also got his Saudi Adult Critical Care Fellowship in 2016 and European Diploma of Intensive Care in 2017. He is currently working as a consultant in King Abdullah Medical City, Mecca. Yeah, please go ahead, Prof. Hussam.
Bismillah. First of all, I want to thank Dr. Muhammad, the organizers, Dr. Saad Mahdi, Prof. Samir Ansari. My lecture actually to be take less than 30 minutes, so it is the end. So how to optimize the source control? I have no conflict of interest. There is a consensus that antibiotic therapy and source control are the major therapies for severe infection. Source control has been consistently ignored by many of studies. However, the major exact rule for the source control remaining neglected in the most of the studies, only limited attention in the few literature and studies. The objectives of my lecture actually to clarify the importance of proper source control, to understand what is the proper way or ways to control the source of sepsis, to explain how much the teamwork and the proper plan decreasing the mortality, and finally to or to emphasize the importance of point of care ultrasound in diagnosis and the management of the sepsis. The medical guidelines, it is usually summary of consensus of statement of best practice in healthcare. You obliged to know, but not obliged 100% to follow these guidelines. Surviving sepsis campaign, including the 4F, which is of controlling the sepsis, including the figure it out, fill the tank, fight the bug, and then fix the perfusion. Figure it out by early recognition, and the fill the tank by proper fluid resuscitation and the close monitoring of the responsiveness, and then fight the bugs. To fight the bug, you need to start proper antibiotic, as Dr. Adil mentioned, and proper source control also. Finally, fix the perfusion by continuous monitoring of the lactate, by continuous keeping the MAP more than 65 or keeping it perfusing, by continuous keeping eye on the organ perfusion, and plus or minus using the vasopressors and inotropic support. Based on surviving sepsis campaign, they recommend as soon as identify the source of sepsis and as soon as do something to intervention to control it, as soon as medically and logistically practical. If there is line and you assume this line is related to the sepsis related line insertion, please secure another one and insert another line. This based on the surviving sepsis campaign. The impact on survival. The impact of source control seems to be unrelated to administration of proper antibiotic. Both are independent predictors. The delay of initiation of the antibiotics and the delay of initiation of proper source control associated with mortality. But there is a consensus that without adequate source control, antibiotic therapy have little, if any, effect. Blues published in Critical Care Medicine 2014 a study. Conclusion of this study that the delay of the source control more than 6 hours associated with increased mortality. However, initiation of antibiotic therapy associated with improved patient outcome. But he found also there is poor compliance among the critical care health providers they are not following the resuscitation and the guidelines bundled. He also, in 2017, he published Medusa trial. In Medusa trial, he find also that any delay of the antibiotic or source control associated with mortality. Maria Martinez, she published in Spain a prospective trial about 4,000 patients. She found, despite the great severity of the condition, there is worse compliance with the resuscitation bundle. But she found that there is a decrease, markedly decrease in the mortality in the patient receives proper source control. Our lectures will focus on big three questions: who and when and how. How patient for source control, and when and how to control it. If we consider this is our paradigm for sepsis, we have a source, we have a weapon, and we have traditional enemy, which is the time. We need to answer, who is a patient candidate for source control? What is our time frame and when we should control it? And what is our tools to control this source? The first question is the source of infection. The source of infection can be not amenable, yani we have no source can be controlled by usual source control, and other sources are amenable for source control. Not amenable for source control like meningitis, sinusitis, pneumonia, infectious diarrhea, cellulitis. Most of these infections, there is no source can be controlled by usual source control, like debridement or drainage or de-obstruction. However, in some other infection, like which is amenable for source control, like parapneumonic effusion, can be controlled by insertion of a drain or chest tube. Acalcular cholecystitis can be controlled by insertion of cholecystomy drain, abscess, open and drain, and GIT ischemia, open, resection, re-anastomosis, pyelonephritis obstruction, insert nephrostomy, insert nephrostomy tube or ureteric stent. And finally, if it is line-related sepsis, you should remove this line after securing another line. This mandate head-to-toe assessment of our patient, from head to toe, from back to back, examining all holes, the oral cavity, the nasal cavity, the external auditory meatus, the anal orifices, the perineum, and should be go as a formal assessment of patient to answer the question, where is the source? The second question in our paradigm is, what is our tools? What is our weapons to fight this source of sepsis? Actually, the ideal source control method should be effective, meaning should be in one tool, by one tool, you should cover debridement, drainage, the de-obstruction, restoring the function and anatomy in no time, without need of surgeon and anesthesia, without need of consent, without need of transportation of the patient from the ICU to OR, without physiological derangement as a collateral damage from our intervention. This mission seems to be mission impossible. The 5 Ds to control the source can be surgery, which is definitive, just debridement, drainage, device removal, and de-obstruction. However, the surgery is the most effective as regards drainage, debridement, restoration of the function. We have a lot of conflict as related to the consent taken, the time to intervention, and the need to transport the patient to OR, and the physiological derangement and the collateral damage related to surgery. Debridement less than drainage and debridement can be done by the debridement only, and no restoration of the anatomy of the function, less conflict, less time, less transportation. The drainage, by putting a drainage tube by intervention radiologist, it will help in drainage. Little for debridement, no role in the restoration of anatomy of the function. The consent to conflict is less. Time to intervention is less. No need to transport the patient to the OR. You can do it bedside. And finally, deobstruction. And deobstruction, it is a subtype from the definitive or the open surgery. The third question, our traditional enemy. What is our time frame? We can control the source of sepsis in it. Based on surviving sepsis campaign, they recommend controlling the source of infection as soon as medically and logistically practical. And they put a time window from 6 to 12 hours. Royal College of Surgeons, they recommend for abdominal sepsis to control the abdominal infection within 6 hours, or immediately push the patient to OR if he's in septic shock. SIS, or Surgical Infection Society, they recommend for abdominal sepsis time window up to 24 hours, but immediately push the patient if the patient in septic shock again. Japanese G published in 2014 in Critical Care Medicine, if the patient in GI perforation, the optimum time to shift the patient to OR within 6 hours. Less than 6 hours, you will improve mortality and decrease mortality and improve survival and outcome. Again, so we have delay of sepsis and we have greater impact of source control on survival. We need to know why there is delay. Why there is delay? However, there is a mortality related to sepsis up to 20% worldwide. The delay can be related to delay of diagnosis. Delay of diagnosis may be related to underestimation of sepsis, no formal clinical assessment of septic patient, reluctance for using point-of-care ultrasonography, use improper diagnostic tool, like asking radiologists to do CT abdomen without contrast to rule out abdominal sepsis. How to correct it? By continuous education, formal local guidelines and sepsis management, optimize the use of point-of-care ultrasonography, multidisciplinary approach. Another reasons related to the delay of intervention. Why? There is no ER theater, no availability of ER theater, no availability of intervention radiologists 24/7. Availability of source control oriented surgical, not any surgical team, should be source control or sepsis source control oriented surgical team. Instability of patient, complexity of the condition and situation. In 2014, Professor Jean-Louis Vincent created the term of sepsis team or sepsis alert team. Sepsis alert team had a lot of tasks. Insertion lines, take a sample, hemodynamic monitoring, administration of antibiotics, even initiation of mechanical ventilation, and sometimes initiation of the source control. This team not including the doctors and the nurses only, but also infectious disease specialists, radiographers, phlebotomists, pharmacists, even surgeon, depending on the local resources of your institute. Each member of this team should have a predefined task, and the leader should direct and coordinate between them. This team should be available 24/7. And there is some institutes containing what's called choke room. However, the choke room, there is the team will stay there, and this room will be equipped by all necessary monitoring devices, intravascular lines, and phlebotomy equipment. It is not only the players, but also the plan. The team coach or the team leader should put immediate goals, like how to prevent the source control, how to prevent the contamination, eliminate the source, if there is source ready to be eliminated, like removal of the line, insertion of the drain, and in the same time, avoid more hazard, avoid more damage for this patient, avoid transportation of unstable patient. Case break. Please prepare yourself to answer this question. Very important for us. Mr. Donald, 70 years leukemic patient, on mechanical ventilation because of hospital-acquired pneumonia. At 3 a.m., he developed new onset hypotension, no clear source of sepsis, but his abdomen is markedly tense and tender. However, with adequate resuscitation and broad-spectrum antibiotics, he remained in refractory shock state with rising lactate. We started vasopressors, hydrocortisone started also. Point of care ultrasound showing free fluids, turbid free fluids, intra-abdominal, normal LV and RV size and function. 1 hour later, patient became anuric, hypothermic, high anion gap metabolic acidosis. The question now, what is the best management plan? Please prepare your answer and you can put it on the chat box. Select from these of answers the best answer. Either discuss the code status and put the patient as DNR, support the patient by all vasopressors, by carb infusion, discuss the case with the surgery team after morning endorsement, send the patient for CT. He is unstable now. Send the patient for CT for diagnosis of the source. OR, it is possible perforated viscous for exploration, lavage, resection, and re-anastomosis. Or OR again, but if possible, it is possible perforated viscous for exploration, lavage, colostomy, backing, and temporary closing. Then send back the patient to ICU for more support, and then in the morning, you can discuss definitive management with the surgical team. 1 minute for collections answers. So, the best answer is OR. Yes, it is OR, but the last one, it is possible perforated viscous for exploration, lavage, colostomy, backing, and temporary closing, and then send back the patient to ICU for further stabilization. Damage control for abdominal sepsis. The answer here. The damage control, firstly, describes this term in the truncal and the abdominal trauma. They took the patient to OR in the stage. The first stage is the resuscitation of the patient in the ER. Then shifting the patient into the OR, where they do primary control of the hemorrhage and primary control of any contamination of the infection. And then shifting back the patient to the ICU for further stabilization and controlling what's called the lethal triad or triad of death, which is the hypercoagulability, acidosis, and finally hypothermia. This stage can be summarized into stage 0, started in the ER. Whereas in the ER, we should focusing on to manage hypothermia, acidosis, coagulation, and with BOTA goals for adequate tissue perfusion, adequate preload, adequate systemic pressure. Then shift the patient to laparotomy. When the laparotomy, they will do resection without primary anastomosis, and then temporary drainage, temporary backing, and temporary closure of the abdomen. Shifting the patient back to the ICU in stage 2 to optimize the fluid resuscitation, protective lung strategy, optimizing nutrition, and the close monitoring for the abdominal compartmental syndrome. Subsequent look or subsequent surgery can be, and finally definitive abdominal wall closure and re-anastomosis. Same case, the patient returned back to you after OR, lavage done, colostomy done, backing, temporary closing, and now he is better as regards the hemodynamics, improving the metabolic acidosis. 3 days, he started to worse again, with more drop of the blood pressure and the leukocytosis. This is abdominal drain, and the ultrasound showing some perfusion and effusion and consolidation, and finally there is infection from the wound. What is your plan? This is another question. Please, if you have the answer, put it in the chat box. The best answer is either discuss the code status, again, put him DNR, or support the patient by all vasopressor, by carb infusion, discuss the case with the surgery after morning endorsement, send the full septic screen, start vancomycin, removal line, and book for pleural drainage whenever possible. The final is the start of vancomycin, remove central line now, and pleural drainage within 6 hours by point of care ultrasonography, and then call the surgeon for possible debridement as soon as possible. 1 minute allowed for answering. Excellent. So most of us agree about the last answer is the best answer. Start vancomycin, yes. Remove the line. Here in this situation, we have a patient with multiple sources. We have effusion consolidation, we have line, and we have abdominal infection. I will give priority for the abdominal infection. Yes, it's the main cause, but I will start by what feasible. What feasible, I will remove the line, and then by my ultrasound, I put a drain in the pleural effusion. And the same hour, I will call the surgeon or surgical-oriented team to put a plan for debridement as soon as possible. Thank you, Will. The role of focus in septic shock, actually, the point of care ultrasound increasing the detection of the source up to 80% within 10 minutes. Easily taught to learners. Even the novice ultrasound users, without any previous experience in the ultrasound, they can do perfect ultrasounds after focused training course, decreasing a lot the length of stay, especially in the ER. In the daytime, the decreasing length of stay down to 11%, and the after hours up to down 20%, decreasing in length of stay in the ER. We have approach. Yes, we have approach in the septic shock for using an ultrasound. Remember the 3D. 3D is the diagnosis. The point of care help us in the diagnosis, help us in the deranged physiology correction, and finally in the drainage. In the diagnosis, we need to ask ourselves, it is septic shock or other types of shock? So we need to rule out by ultrasound other types of shock. The second D, the deranged physiology correction. By ultrasound guided fluid management, as Dr. Hisham mentioned, the patients needs more fluids according to the indices, and the insertion of central line. Drainage, source control, pleural drain insertion, cholecystomy drain, acetic drain insertion, arthrocentesis, LB sometimes. Professor Daniel Lichtenstein, he is the creator for most of algorithms based on point of care ultrasound. He created what's called the blue protocol in respiratory failure and the false protocol in the shock patient in the ER. This algorithm showing the integration between both the blue and the false protocol. First of all, if your patient is collapsed, so either it is in ER or in the ICU, use your ultrasound machine to rule out the obstructive shock. Rule out tamponade, pulmonary embolism by reviewing the RV. Is any RV collapsibility during diastole, and compare the size and the function between the size of the RV and the LV. Then the lung ultrasound to rule out pneumothorax. So the first question is rule out obstructive shock. Then assessment lung for B lines. If there is extensive B lines, most probably we are speaking about cardiogenic shock. If there is no B line and there is no clear signs of obstructive shock, and we have only A lines by the ultrasound chest, we are most probably speaking about hypovolemic or distributive or septic shock. Give fluid to the patient, either fluid challenge or basofilic raising. If the patient markedly improve, it is most probably hypovolemic. If it is little bit improvement of the hemodynamics and soon B profile eventually generated, it is most probably septic shock. The second, if the septic shock, where is the source? The source can be come from this algorithm, another algorithm. Alonso and his colleague in the emergency medicine, he published this algorithm. To summarize this algorithm, we need to examine 4 areas in the body. We need to examine the heart, the chest, abdomen, and then the soft tissue. The heart, up to 84 sensitivity of the point of care ultrasound to detect the vegetation more than 10 millimeters. Lung ultrasound, early pneumonia, there is B lines and subpleural consolidation. Later can be there is air bronchogram, or even what's called Schritt signs and dynamic bronchogram also. Abdominal examination to rule out acalculable cholecystitis. The BOCUS highly sensitive and specific to detect acalculable cholecystitis also. The appendix they found, especially in pregnancy and especially in the pediatric group, there are high sensitivity of using BOCUS in detection of the appendix. Pseudo kidney sign as a sign of diverticulitis. It is very important to rule in diverticulitis by using BOCUS as a bedside. Finally, if there is hydronephrosis like this, can be source of sepsis and it can be managed easily by insertion of ureteric stent or nephrostomy tube. If there is no clear source in the heart, kidney, heart, abdomen, and in the chest, please check the soft tissue. Soft tissue to diagnose cellulitis or even necrotizing fasciitis. There is 2 signs here, the cobblestone sign in the soft tissue in the cellulitis and what's called dirty shadow in necrotizing fasciitis. Take home message. With high respectability for the 1 hour bundle, we should change our mind. We change our mind from 1 hour bundle to what's called extended 1 hour bundle. So 1 hour bundle including lactate, insertion of line, give fluids, antibiotics, vasopressors, but we should extend our mind and our thinking to what's called extended 1 hour bundle, which include patient again. Please go assess your patient from head to toe, from back to back, every holes, and then assign your players, put a team, assign the task for each team, and put a plan. What is the early goals? What is the goals should be done now, and after 2 hours, and after 3 hours, and after 4 hours. BOCUS and BOCUS and BOCUS in the drainage, in the diagnosis, in the intervention. Use the BOCUS everywhere. If the patient collapsed again, reassessment him by BOCUS also. Finally, try to change your institute and your hospital policy and protocol, and put a plan for education as regard teamwork, simulation, and point of care ultrasound. Thank you very much.
Great. Fantastic night. Okay, Dr. Mohammed.
Thanks very much for that nice, thanks Dr. Sam for that nice and informative lecture. Really appreciate it. It's been a great day. So the first and last lecture just taught us how to play as a team, how to apply the care bundle appropriately, as you probably learn from this, and just remind ourselves how to play as a team all together, and every member has got a definite role. The second lecture just remind us how to apply the pathophysiology, how to use the pharmacology to apply the appropriate treatment and modify it accordingly, according to the patient. And the third one by Dr. Sarwat just informed us how to use the research as a tool to guide our practice. So it's all about that great teamwork and different rules as a team. I'd like to thank all the panelists, all the attendees, all the speakers. I'd like to thank Dr. Saad for this tremendous effort that done ways before the session. Prof. Samir Ansari and that attended this and helped with this to come this to live and make it a successful day. Hope you've enjoyed, and I'll leave the mic to Dr. Saad.
Thank you. Thank you.
Thank you.
That's a little thanks from the MEGA online course tonight. And I believe that the third night modular teaching, and it proved very well that bunch of lecture tonight and under hosting of Prof. Ansari, who's honoring us by his presence tonight, and moderator Dr. Muhammad Mahmoud. I would like to especially thank Dr. Sarwat Isa, who is organizing this webinar tonight. Since June, we are working hard to get those expertise on board. And I would like to thank you very much for this lucrative tonight. And the feedback is absolutely wonderful and excellent, informative lectures. I am so overwhelmed about the amount of knowledge I learned tonight and experience, and those protocols, guidelines for sepsis, which is still the biggest challenge for any intensivist in intensive care unit. Next Sunday, we have another modular teaching in MEGA online course. We have obstetric webinar. We have again Professor Ansari, who is going to teach us about intensive care for obstetric case discussion. And we have Professor Fahmi Saad, who is going to teach us about obstetric with congenital heart disease. And the other star, Professor Amr Al-Fattah, is going to teach us about why regional anesthesia fail in obstetric. The moderator for next Sunday is Professor Nasreen Rifai, who is very famous, professor of anesthesia, and Dr. Mahmoud Al-Khulani is going to be here next Sunday. From myself and my colleagues, organizing committee, on behalf of everybody, I would like to thank you for your support tonight.
Thank you.
Thank you. Thank you.
Thank you, Dr. Saad.
Thank you.
Thank you.
Thank you very much.
Thank you, Dr. Muhammad.
Thank you.
Thank you.
Coordinated day, Dr. Saad, really.
Thank you very much, Prof. We are so honored.
Really, I am enjoyed from these lectures.
I am so honored to say that. Thank you.
Lectures are highly, highly attractive, really.
Thank you.
Thank you, Prof. Thank you, Prof.
Thank you. Thank you.
Thank you.
Thank you.
Thanks,
Okay.
everybody.